Welcome to Jinesh, who is a GP, and he's a GP with an extended role in dermatology, which means he has a particular interest in dermatology. And Jinesh is also a clinical lecturer at Queen Mary and University of Hertfordshire. So I'm going to hand over to Jinesh, and his session is going to focus on the management of skin cancer in primary care from a GP's perspective. Thank you very much.
I'm going to be talking today about management of skin cancer in primary care, and I'll be focusing mainly on the treatments that, for instance, I offer in primary care, or that we offer in a community dermatology setting. I'll be briefly touching on the treatments that they offer in tertiary units, but not in much detail. So by the end of today, we would have been able to tell us a little bit more about the referral criteria for suspected skin cancer, so the current changes in the referral criteria, and we'll talk a little bit more detail about the current topical treatments that are available in the NHS. We'll talk a little bit about skin surgery, and we'll talk just very briefly touch on biologics. So you've been talking a lot today about skin cancer, so we won't go over the different types of skin cancers again, but we'll just talk a little bit about the pathway. So currently, if you suspect somebody has a non-healing ulcer, so you suspect a squamous cell carcinoma, you would refer under the 2-week wait pathway. So this usually is classified as a non-healing crusted lesion that's been there for longer than 8 weeks, rapidly growing. You would generally tend to refer that on the 2-week wait pathway. The same applies for melanoma. For melanomas, we have a 7-point checklist, which is based on the Glasgow score. And the checklist looks at things like changes in size, the presence of 2 or more colors, any irritation or itch on the mole, or for instance, any change in the shape or rapid growth of the lesion. You'd score more points. So if you score 3 or more, you'd refer it as a 2-week wait. So that's the current criteria for referring a pigmented skin lesion. And obviously, if you thought it was a nodular melanoma, you'd refer that straight away. So the other thing is, if you're familiar with dermoscopy, you can use your dermatoscope, and if you find any features that are suggestive of melanoma, you'd also refer that under the 2-week wait. And in some settings, you would biopsy. And if the biopsy came back as a suspected skin cancer, you would then refer that onwards on the 2-week wait pathway. We'll talk a little bit about biopsies later on, but if you thought that something was cancerous, you wouldn't biopsy it in primary care. You would send that off as a 2-week wait. The only time you would biopsy in primary care is if you were unsure. If you thought it was benign, but it didn't have all the benign features in there, then you might think about doing a biopsy. And if obviously came back, you would refer. BCCs are a bit different. So BCCs generally, if they're not on the face, if they're not on areas which we call the high risk areas, which are around the eyes, on certain parts of your nose, and on the ear. So high risk areas you would refer as a 2-week wait. But if a BCC, for instance, was on your shoulder or on your chest or on your back, you would refer that routinely. So that wouldn't be referred on the 2-week wait pathway. And that's because generally BCCs are very slow growing. They don't metastasize. They're locally quite invasive. So if they were around your eye, for instance, you'd want to get that removed pretty soon, because if it is locally invasive, the skin around your eye is pretty thin, and to then carry out a big graft, it would then result in a big cosmetic change for the patient's appearance. So you tend to refer BCCs if they're around high risk areas on your face earlier, and that would go under the 2-week wait pathway. But if they're anywhere else, you refer that routinely. So really, you're referring any suspected squamous cell carcinoma or suspected melanoma on the 2-week wait pathway. Now, recently things have changed. So there has been. I'm not sure if this is applicable to the whole UK, and if it's become nationwide. But I know certainly in London, particularly in the Barts NHS Trust where I work, there has been a change that we are now triaging 2-week wait referrals slightly differently. So if the patient is above the age of 18 and they have less than 3 lesions of concern, and those areas are not in a private area, an intimate area, and the patient is happy to consent for the photos to be taken, they're seen in a hub. And these hubs have been scattered around London, around different areas, different boroughs of London. They'll be sent an invitation to visit the hub, where dermoscopic photos are taken and photos of the skin lesion are taken. These are then sent to a consultant or a clinician, and they're triaged. And if it's appropriate, then they're seen in the 2-week wait clinic. If the lesion is found to be benign on dermoscopy, and it's not appropriate for a 2-week wait referral, the referral is converted to a routine referral. And if it's something which can be managed in primary care, they'll write back to us. So this is helping to reduce those big waiting lists that they had previously for the 2-week wait pathway. So far it's working really well. And that brings me to another really important aspect of management of skin lesions. And one of the things that has become more and more obvious is that we're using more and more technology. And one of those things is clinical photography. So since COVID, a lot of us are taking pictures, whether it's on our personal devices or whether it's on a hospital, if you have a camera at your surgery or practice or at the hospital. So we're taking pictures, we're storing them depending on what program you're using. For instance, I use Pando, but there's lots of different compliant apps that you can use as well, which are GDPR compliant. But ultimately, you take photos because it allows monitoring over a period of time. So if you have a skin lesion and you're not sure whether it's, if the patient's unsure about it and you think it's most likely benign, but you just want to keep an eye on it, one way of monitoring it is to see the patient in 6 months' time and see if there've been any dynamic changes. So that could be dynamic changes macroscopically or dermoscopically. So the best way to do that is take clinical photos, gain the patient's consent, store those photos in an appropriate platform like Pando, and then review those photos with the patient by your side again 6 months later, or depending on how urgent you feel the patient needs to be seen, bring them back. So photography is really, really great, and it should be clinical photography. So it shouldn't be photos that the patient has taken, because often they will be of less high definition quality. So if you have appropriate software available and the technology available, make use of it. So for instance, in the local practices where I work, we have had funding from the ICB to buy the dermatoscopes which fit onto your phone. And most GP practices have them, and they allow you to take very high quality dermoscopic photos, and then you can use another device to take the macro photos. And so that's a really great way of storing patient photos and then comparing it over a certain period of time. The other reason you should take photos is if you ever do treat a skin lesion, even if it's just cryotherapy or just a topical treatment, it's always useful to have a photo of the lesion before treatment. And I think in terms of particularly medical legal reasons, if you get the diagnosis wrong, for instance, or if something happens, and just to protect yourself and the patient, it's really useful to have those photos from beforehand. And I think that's another reason that I would stress that any skin lesions that you see, photograph them as long as the patient consents. So moving on, so we're going to talk a little bit about topical treatments and their uses and their pros and cons. So one of the most common things that I prescribe in primary care for skin cancer is Effudix 5-fluorouracil, and this is a topical chemotherapeutic agent. And more often than not, I use it for actinic keratosis. Very occasionally, I've used it for superficial BCCs, but most of the time I'll use it for actinic keratosis. And these are usually crusted, as you've seen on the previous lectures, crusted red patches or macules on the scalp or forehead or sun-exposed sites. And you tend to just use this over a course of 4 to 6 weeks. I generally use it for 4 weeks, reassess the patient, and if they need further treatment, we can prolong the treatment if required. So the application is once a day. You apply Effudix on the affected area once a day. If you're treating more than one area, so we call this field treatment, particularly on the scalp, you might have loads of actinic keratoses, you can apply it on all those all those affected areas. But what I tend to do is I'll get the patient to treat one area first, because if the patient's never used Effudix before, they're probably going to have a reaction. And this happens with a lot of the topical treatments. So Effudix causes a very inflammatory response. So you get this redness, this tenderness, erosion and crusting. And this usually happens within a couple of days of starting the treatment. And often this puts patients off. And so patients will, come back and say, well, I stopped treatment after a week because my skin went really red and sore. So it's really important that you explain to patients that you will have an inflammatory response. It will go red. It will become a bit tender. It might become a bit crusted. And that is expected. And that's often a good sign of response to treatment. And so you do want a bit of that response to confirm to yourselves clinically that this treatment is working. It's suitable for sensitive areas. So what you can also get actinic keratosis on the lips. We call it actinic cheilitis, and I often use this on the lips as well. So it's safe for those areas. It's safe for areas around your nose, around your eyes, where the skin is slightly thinner, and so it's a really good treatment to use. But the only thing, of course, is you must warn your patients. It's a non-invasive treatment. And the way 5-fluorouracil works, it's a chemotherapy agent. It works selectively by targeting abnormal cells, which the cells which are replicating rapidly, it interferes with the DNA synthesis. As I said, there are other indications. You can use it for superficial BCCs, but of course you'd want to probably use it for slightly longer and monitor the lesion over time. So if they're superficial, bring them back again in 6 weeks, have a look at the response. If there's been very minimal response, I'd probably want to think about an alternative treatment. Nowadays, there's a treatment that many of you may be familiar with. It's called Actikerall. And Actikerall is essentially 5-fluorouracil, so it's Effudix plus salicylic acid. And this is super helpful for those very crusted actinic keratosis, those ones of which are very thickened and where you want a bit of that scale to be dissolved in order to get that Effudix deeper into the skin. And so Actikerall is super useful for those very thickened actinic keratoses. Another treatment that I don't personally use very often, but a lot of my colleagues do because it's a little bit better for the skin in terms of the reaction that it causes on the skin, is Solaraze or diclofenac sodium 3% gel. Now, this treatment, again, readily available, can be prescribed by clinicians. It can be used for very early AKs. It is an anti-inflammatory, so the mechanism of action is slightly different to 5-fluorouracil, which is a chemotherapeutic agent. And the application is slightly different. So here you have to apply the treatment twice a day, and it's usually for up to 90 days. So that's a lot longer. It's about 3 months course. And so you've got to use it for much longer to see whether you get a response to it. It is better tolerated in terms of patient feedback. It tends to cause less redness, less irritation. And so patients prefer it, in terms of versus Effudix, it's more preferred by patients, but clinicians prefer Effudix because it works slightly faster. It does have a slower onset of action. And the other treatment that's available is Aldara. I know there was a stock issue a few months ago with Aldara. There's always a stock issue with a lot of topical treatments, but Aldara is another treatment that you can think about. This is applied slightly differently. So this is applied thrice weekly, so 3 times a week for 4 weeks if you're using it for AKs. So for actinic keratosis, it can be used. It can also be used for superficial BCCs. And occasionally it can be used for Bowen's disease as well, which is your full thickness or squamous cell carcinoma in situ. The way Aldara works, it stimulates an immune response. So it causes the immune system it tracks the immune system to the affected area, creating an inflammatory response. And so here you will also see redness. You'll see crusting. It might become a bit tender. And I'd avoid using this, of course, if before a social event. So if you've got patients planning a wedding, or if they're going off on a holiday a week later, perhaps start the treatment after they come back from holiday or after their social event, if appropriate. It's also suitable for sensitive areas like the face and neck. The only thing to inform your patients about is they may develop flu-like symptoms during treatment. If that occurs, they should contact you and you should stop the treatment. Now, this is a treatment which I haven't personally prescribed yet, purely because of cost. It's a new treatment that's been around a couple of years now, but it's a lot newer than the other treatments that I mentioned. And this is called tirbanubulin ointment. So it's a very relatively new treatment. The great thing about this is it only needs 5 days of treatment for AK. So remember, Effudix 4 weeks, imiquimod 4 weeks, Solaraze or diclofenac we said was about 3 months, and this is only 5 days, so a lot shorter. So in terms of getting the effect, the desired effect that you want, quick, but it's expensive. It does also cause a bit of redness and discomfort during treatment. There is some research whether this can be used going on at the moment, whether this can be used for superficial BCCs. It hasn't been licensed yet, but whether that's going to change this year, I'm not sure. But at the moment, it's only licensed for AKs. And the way that it works is it interferes with cell division. So those cells that are dividing rapidly, it will only affect them. So it won't affect your normal skin cells. Coming on to, so we've spoken about topical treatments. Now we're going to talk a little bit about photodynamic therapy. Now, photodynamic therapy is another treatment modality. It's not really available much in the area where I work. The availability is limited, but I know in other areas of England there is more available. And this is a great treatment, again, it's a non-invasive treatment for skin cancers, superficial skin cancers, particularly superficial BCCs, AKs, and Bowens. Now, this uses a photosensitizing cream. So it's 5-ALA, and this is absorbed by the cells which are rapidly dividing. And it causes these reactive oxygen species to be formed through light activation. It's a red light that they use. It's a special device that is required. And this red light causes activation of this photosensitizing agent, which causes production of radical oxygen species or reactive oxygen species. And this destroys the abnormal cells. And that's the way that it works. Often patients may need more than one treatment, but overall it has a really good cosmetic outcome. It doesn't cause any deep scarring. It can cause a bit of pigmentation, but it's generally well tolerated. The actual treatment with the red light lasts up to about 10 minutes, so it's not a very long treatment that they require under the red light, so it doesn't take up too much of their time. And you can treat large areas as well. So as we mentioned field treatment previously, when I spoke about Effudix. So if you had multiple AKs on the scalp or the face, you could treat multiple areas at the same time. The only downside is a patient should then avoid direct sunlight for the next 48 hours after treatment, because they have had this photosensitizing cream applied and it will react to sunlight. So they need to be away from the sun for up to 48 hours. But most patients, it's not too much of a concern. But it's not suitable for deeper cancers. So cancers like nodular BCC or infiltrative types of BCC, not appropriate. There's another branch to photodynamic therapy, and that's home PDT. And this is suitable for maybe older patients or patients who can't get to the hospital or who don't have time to go to the hospital, or where the nearest hospital is very far away. So this is where they use another photosensitizing agent. They can also use, there's another type of 5-ALA they can use, or there's MAL that they can use. And this is applied on the skin. This is usually prescribed by community dermatology clinics. And basically the patient needs to go out for 2 hours in the sun. So they apply the product over a certain period of time. They go out in the sun. They need to stay out for about 2 hours. So they need to go for a walk in the park, for instance. And then the same sort of reaction will occur where they get reactive oxygen species form, and that those will destroy those abnormal cells. This tends to be better tolerated than conventional PDT. It's less painful, but it's really helpful for patients where other treatment modalities aren't appropriate. Cryotherapy. So cryotherapy varies from area to area. In my particular practice, we don't actually have a cryotherapy canister. So these are the ones where you have to get a company's contract, you get them refilled. We actually use a product called Hydrazid. And Hydrazid comes it's about £50 a bottle. It comes in a can. You don't have to get it refilled. You just buy a new one when you run out. Has the same sort of product, liquid nitrogen in there. And this we use for Bowens, AKs, and superficial BCCs. It has lots of uses where surgery may not be appropriate or where the patient has declined surgery. The great thing about it is it's relatively, it's quick. Takes less than 5 minutes. The only thing is you need to have the spray available, and you need to consent the patient appropriately. So inform the patient that there is a risk of blistering. It can cause a bit of hypopigmentation and scarring occasionally. So just make them aware of those side effects, and sometimes it may not work, or they may need more treatments. The downside about cryotherapy is if you in the future will then require a biopsy or you need to excise it, the cryotherapy distorts the histology for the pathologist. And so the pathologist won't be very happy with the sample that you've sent, because a lot of the tissue will have been destroyed through a cold burn from the cryotherapy. And so it's not a great idea if you're thinking, okay, maybe we might have to biopsy in 6 weeks' time if it doesn't improve. So in that case, I would avoid cryotherapy. But if it's something that you're certain it's most likely to be AK or Bowens, and you're happy and the patient doesn't want to have a biopsy, then it would be appropriate. It's widely available, it's minimally invasive, and it only requires a few sessions. Now remember that there's a video I've got at the end here after this slide. So I'm just going to play this video and we'll just talk through a little bit about how it's applied. So you can see that the cryotherapy is applied, and you tend to just, depending on how deep or how superficial it is, you just freeze for about 5 seconds, let the lesion thaw, and then you might repeat the cycle. So I often repeat the cycle 2 or 3 times. So you can see this clinician is treating multiple areas. So just for a few seconds. I think on the face, you tend to use it for a few seconds. On other areas of the body, depending on how thick the lesion is, I tend to go for a little bit longer. So I'll usually do 5 to 10 seconds. And occasionally, if it's very thick, we might go up to 20 seconds if required, depending on how thick the lesion is. But it's quite easy to train clinicians to use this. And as I said, depending on what your local agreement is, you can either buy the Hydrazid or you can get a contract with your local cryo company. The next thing I'm just going to talk a little bit more detail about is what I do is derm minor ops. So a lot of the times we're referred patients who have skin lesions. The diagnosis is uncertain, but the clinician hasn't felt that the patient needed to go off on a 2-week wait. So often it may be that they're just unsure, or it might be that they might be thinking low grade, so they might be thinking Bowens or actinic keratosis or dysplastic nevus. And so they're often referred for a skin biopsy. Now, depending on what the skin lesion is, we offer different types of surgery. So for instance, if you were thinking about a pigmented nevus, so a pigmented lesion or a mole, you'd probably want to do an excisional biopsy. You'd probably want to cut the whole thing out if it was appropriate, and send that off. But for things like AKs or Bowens, for instance, or even superficial BCCs, we offer shaves or deep shave, and I'll talk you through that in a moment when I show you some videos. Or we might offer curettage and cautery, so that's using a curette to just shave off the layers until about the superficial dermis, and then we usually burn the top. The advantage of this is that even if you do a punch biopsy, or even if you shave the lesion, you can send it off for histology, and that allows the pathologist to have a look at the depth, to have a look at what type of cells are in the sample, and to come back to you with a diagnosis as to whether it needs to be cut down further, or whether the patient can be reassured and just monitored. So it gives you a lot more information. So histology is really helpful. So we're going to watch a video on punch biopsy. So punch biopsies are generally done in a primary care setting. We have a special clinic dedicated to them. So local anesthetic, in it goes. Of course, you'd consent the patient beforehand. And you can see the wheeling of the skin with the local. You can see that pink pigmented lesion there. And this looks like quite a large punch, probably like an 8 mm punch. And then that punch goes down right down to the fat, so right down to the subcutaneous fat, removed, and then we close up. So that sample, that section of skin with the epidermis, dermis, and subcutaneous fat, go off to the pathologist. If it was a melanoma, for instance, the pathologist can now comment on the Breslow thickness because you've gone right down to fat. And that's the key with punch biopsies. You must go down to fat so the pathologist has enough information. And of course, you've got to be careful. Obviously, if you're doing a biopsy on the leg, you need to think about, is the patient diabetic? Have they got venous disease of the legs? Are they more at risk of wound dehiscence or wound breakdown? So these are things that you've always got to consider, and you've got to sort of weigh it up. Do we need to biopsy this, or should this be sent to secondary care where the plastics can become involved and where they may need a graft? So you've always got to be sensible. And obviously with my patients, if they're diabetic and the diabetes is poorly controlled and the biopsy can wait, we generally will just wait until the HbA1c is improved or their leg circulation's improved, and then we would reconsider whether the biopsy needs to be done. Or we'd think about alternative treatments. So just some more videos. This is a shave biopsy. So shave is more appropriate for things like actinic keratoses or Bowen's disease. And this can be a second line treatment. If you've tried a topical treatment and the topical treatment hasn't worked well, so they've come back 4 weeks later, hasn't responded to topical treatment, they haven't had that red reaction that you get after Evudix, then it might be appropriate for a shave biopsy. And then you tend to use something called a derma blade, one of the most sharpest blades you'll ever come across. It will really nicely cut the skin in a sort of like a very, very shallow cone. And then you can see there, we just cauterize the top, apply some ointment, some Fusidin ointment, and on goes the plaster. So again, very, very easy to perform in a community-based setting. And lastly, these are excisional biopsies. We perform these for BCC. So BCCs can be removed in the community. We often, even if they're nodular, we remove anything below the neck. So this is a melanoma. We don't remove melanomas in the community. They must be removed in a tertiary or secondary unit. So these melanomas are never removed in primary care or in a community clinic, only BCCs. And the same applies for SCCs and melanomas. So melanomas and SCCs, always secondary care. But again, you can see this elliptical incision. They're cutting down all the way to fat. That yellow bit that you see there that's all fat. That's all the subcutaneous layer. So notice how that section has been cut all the way down to fat with the subcutaneous layer. Off that goes to the pathologist. And now they can comment on the Breslow thickness and the margins. Look at the margins. So it's got at least, I would say, 3 centimeter margins there. So quite big margins. And then we're going to put some intradermal sutures in. So you can get that wound closed up with usually some Vicryl or monocryl. That looks like monocryl there to me. So these are absorbable sutures, and just bring that wound edge together, and then usually close the top. So more intradermal sutures there. So obviously you've got to start thinking, if this is on the leg or if this is on any high risk area on the patient. Think about how the wound will heal. Think about potential complications, infection, bleeding when they get home, wound dehiscence, keloid scarring. These are just some of the things that you've got to think about before a patient goes off for a biopsy. And that will obviously leave quite a big scar. Okay, so another component of surgery which I'm not going to talk on in too much depth is Mohs surgery. So Mohs surgery is always performed in a tertiary unit, and this is a very, very specialized type of surgery. This is where the cancer is removed layer by layer. It's more appropriate for cancers on the face. So as I mentioned before, if you have a BCC around your eyes or around the margins of your nose, or around the lips, you might want to use Mohs surgery. The trouble with this technique is there aren't that many surgeons that are trained with Mohs. I mean, there are more and more now, but they're not available everywhere. And so it really depends on your center. And so most centers will have one Mohs surgeon. And it's a very specialized technique. So here you remove layer by layer of cancer, and you have on-site histopathology. So there's a pathologist there that's reporting on how deep you need to continue going. So if you've got down to a certain depth and there's no cancer cells there, you can stop. And your pathologist, you will be relying on your pathologist to give you that information. So you've got on-site histopathology, real-time histopathology. It's done as a day-K procedure. The great thing is it's tissue sparing. So, areas around the eyes and nose where you want to preserve as much tissue as possible, it's a great technique. You can also use it on high-risk areas on your legs as well. It's not unheard of to use Mohs on the legs, but it has to be done in a specialized setting. The curative rate is 99%. So it's got a huge, very significant curative rate, and which is why it's such a great form of surgery. But as I said, not available everywhere. And now coming on to biologics. So far we've mainly spoken about SCCs, BCCs, superficial skin cancers such as precancerous lesions such as AKs and Bowens, and we've touched on superficial BCCs as well. But I haven't spoken a lot about melanoma or pigmented skin lesions. Most pigmented skin lesions, as I mentioned, would go off on the 2E8 pathway, where they would then have the skin lesion excised, so the mole would then be excised, as we saw in the video prior to this with the elliptical excision. But we haven't spoken a lot about melanoma because a lot of the treatments now post-surgery are related to biologics. Now, biologics have really changed treatment for lots of skin conditions, not just skin lesion management, but also for inflammatory skin conditions like eczema and psoriasis. And I'm just going to very, very briefly outline the biologics that are available and just talk a little bit about how they work. So some of the treatments that we use for melanoma, for instance, are the BRAF inhibitors. And the BRAF inhibitors block cell division. So those cells that are rapidly dividing, the way that these biologic treatments work, they block those cells. And they block them through very specific pathways involved in cell division. Now, you can test whether a melanoma is BRAF positive. There's a special test staining technique that they can use on the sample that you send off, and that will help patients to have targeted treatment. So if your tumor comes back as BRAF positive, and particularly BRAF V600E positive, you can then be considered for this particular biologic, which in this case is called ipilimumab. Okay, so this is a particular targeted treatment for BRAF positive melanoma. Other targeted therapies, for instance, work by the immune system. So there's the PD-1 inhibitors and there's the CTLA-4 inhibitors. And essentially they work by stopping the cancer cells from switching off the immune response. So cancer cells get very clever and they turn off the immune response. So they'll turn off those T lymphocytes, and they have ways of doing that through these receptors. But what these biologics do is they prevent those T cells from getting turned off. And so those T cells will remain activated and they will help to attack those cancer cells. And so very clever ways of working. And lastly, there's a treatment which is the TVEC, which is at the bottom here, and that uses a genetically modified herpes simplex virus, so HSV1, and it's genetically modified. And what it does is it replicates within the cancer cells. So it's genetically modified, so it's attracted to the cancer cells. It goes inside the cancer cells, it replicates inside, and it causes destruction of those cancer cells. It causes cell lysis. So again, all these treatments have really revolutionized how we treat melanoma and other forms of invasive skin cancer. Because obviously, as I mentioned previously, a lot of these treatments will have an implication for your patients who have many other comorbidities. If they have a diabetic foot, if they have venous disease of the legs, you do need to consider what treatments are appropriate depending on your patient's background. And I think what you really need to consider is blood supply. So we know that the pre-tibial areas and the ankle have a poorer blood supply. So if you're doing an excision or a biopsy there, you need to be more cautious and perhaps need to think, well, is this appropriate for my level of expertise? Does this need to go after plastics? Or do we need to plan this properly? Do we need to give the patient compression hosiery for a few months, if appropriate? Or do we need to get the HbA1c under control? Or does this patient need to have a vascular referral first before we consider surgery? So you need to think about, the patient and their comorbidities. The other thing is those areas also have delayed wound healing and an increased risk of infection, particularly lower down in the foot. And so, if your patient has poorly controlled diabetes, do they need to be cross-covered with antibiotics? Do they need topical antibiotics? Do they need regular reviews? These are things to think about. The thing that I find really difficult is an elderly skin, it tends to lose the elastin and the elasticity, and the recoil of the skin diminishes with age. And particularly, on the leg, when you're suturing on the leg, the skin tears really easily. And in these patients, it can be really tricky to get a nice wound closure. And so this is also another thing to think about, is what type of suture material will you be using? And will this patient be at risk of wound dehiscence? Will they need to heal by secondary intention? Are they more likely to develop an ulcer? So again, more to think about. And particularly where you're thinking high risk, where you're thinking they will probably need a skin graft or a flap, then you probably want to think about referring to plastics for surgery. And they have the equipment, they have the expertise to carry out these procedures using skin grafts. Where appropriate, where the patient has leg edema or venous insufficiency, I think it's important to manage those things first. And obviously, if you've got a patient with a melanoma and it's nodular, you want to get it cut out straight away. So you don't really have a lot of time to think about leg edema and venous insufficiency. In those circumstances, get the lesion cut out and then manage the problems afterwards, the other comorbidities. But it's important that where it's appropriate, where you can manage the other comorbidities first, get them sorted out before you get the patient booked in for surgery. Where surgical treatment may not be appropriate, consider other forms of treatment. So we spoke about PDT, we spoke about topical treatments. We said Solaraze was a lot milder in terms of its reaction. Epidix tends to have a strong response. It tends to cause more redness and more crusting and more erosions. So be wary about, what you use on the leg. But yes, you can think about topical treatments. That doesn't mean that Epidix is completely safe for the leg. You should still use it with caution, but just warn the patient beforehand and assess the skin beforehand. Assess the integrity of the skin. Find out, get a bit of history about their skin, their legs, if they've got any history of any skin diseases on the legs. So that brings me to the end of the presentation. If anybody has any questions, I hope that was helpful, but I'll take any questions now.
Yes, that was really helpful, and thanks for taking us through the options for managing skin cancer in primary care. Are there any questions in the chat? Alexandra's raised an issue saying one of the downsides of PDT is that it can be very painful for patients.
Yes, absolutely. Home PDT tends to be less painful. So that's another thing you could consider. You could also consider cryotherapy. It's painful for a few seconds, if appropriate, but then it generally is well tolerated. The pain doesn't tend to last for as long. It might be a bit sore for a few days, but it generally is better tolerated. The other thing is Solaraze as well. Work takes a bit longer to work. But I think, ultimately you've got to explain to your patients that most of the topical treatments will have some degree of discomfort. Even if you consider surgery, post-surgery, once the anesthetic's worn off, there will be a little bit of discomfort while it's healing. So it's just something to, you've got to tell your patients that there will be some degree of discomfort. Take some analgesia, take some time off work if required. And we don't want to start treatment if they've got a wedding coming up, for instance, or a holiday planned.
I wonder if you've got a comment. It came up earlier that, practitioners, particularly For example, podiatrists or tissue viability nurses can be often reluctant to contact a GP. They might be worried about a patient with a skin lesion, something they've seen. Hopefully, Gemma's session has helped focus them in on that. But, any comments from your perspective as a GP about that?
So the question is whether the podiatrists are quite concerned about or worried about sending patients to GPs.
People know how busy GPs are, and they tend to, what we see in tissue viability is people sit on, they might notice, might be very concerned, um, and they may be just reluctant to raise that because they're not sure, they're not confident. um, Gemma made a point earlier saying knock on the door, raise that with somebody, and it's just trying to get those of us that are non-specialists to come forward.
I think that's a really fair point. I think the trouble is that dermatology doesn't get the attention that it needs in most curricula. So if you look at the podiatry, the nursing curriculum, the PA, even the medical curriculum for medical students, they get 2 days on dermatology for their entire curriculum for the 5 years that they're in medical school. So I think, if you're unsure about a skin lesion, it's fine to be unsure. And I think that the most important thing is to raise it with somebody that might have an idea about what it is. And if you do have access to a GP with an extended role or a nurse consultant who specializes in skin cancer, for instance, or any clinician that specializes in skin, I think that's a point where you can say, well, can I get your second opinion on this? What do you think it is? And I don't think anyone will ever think, oh, this person doesn't know what they're, is incompetent, because I think most people don't know about the skin. And I think, the fact that you've spotted that there's something abnormal there is is going in the right direction. It's just about making sure that you have some sort of follow up for the patient. So, if you've sent the patient off to the GP, follow the patient up after, check that they've been to see the GP, check that the patient hasn't ignored the symptoms, because if it is a melanoma, the patient will then regret, or you will regret that you hadn't followed the patient up. So I think the key is don't be afraid to knock on someone's door, as Madeleine and Gemma said, and also follow up. Check that the patient has done what you've asked them to do.
Okay, I think if there's no further questions, we'll say thank you again to Jinesh.